Good morning, good afternoon, good evening, depending on where around the world you are attending this webinar. This is Heart Week in Australia, and a very special session we've got for you today with an outstanding panel that I'll introduce you to in a moment. At first, though, I'd like to acknowledge the traditional owners of the lands on which we meet, and indeed the Indigenous people around the world, their elders past and present. Could we move the slides on, please? Our panelists tonight are Professor Sandosh Padmanabhan from Glasgow, Peter Saltis from Adelaide, Sophia Zungas from Melbourne, and Jan Radford from Tasmania. And I'm Garry Jennings. I have the privilege of chairing this eminent group. You have their bios, so I won't go into any detail about that, except you can see that they're world leaders in their field. Our subject tonight is residual risk, and I'm just going to introduce that to you a little bit because it may not be clear what we're talking about. As you know, modifiable risk factors account for a significant part of cardiovascular disease globally. We might argue about how much in our discussion section at the end. Absolute cardiovascular risk assessment is a way which is used to integrate these various risk factors, because we know that cumulatively multiple risk factors can contribute to risk in a way that a single estimate of a single risk factor doesn't give you the whole story. And we also know that some people at high risk have only moderate increase in the intensity of several risk factors rather than having a major risk factor on their own. Next slide, please. So this is very familiar to you. We're very used to categorizing people when we do risk prevention in the community and assess their cardiovascular risk. We use various techniques, usually a CVD risk equation, to categorize people into low risk, moderate risk, and high risk. And the implications of that, of course, is that high risk people mostly go on to medications. Moderate risk, everybody gets lifestyle recommendations, of course, may or may not. And of course, low risk we tend to observe. And then we can move very quickly in an individual patient into a secondary prevention mode. And you can see on this slide some of the measures which have been proven to improve outcome in people that have already had an event and reduce the likelihood of a subsequent event. Next slide, please. Now, we could do a lot more than we are now. For example, these two diagrams show you on the one side that almost 3/4 of high-risk people in the Australian community are missing out on blood pressure and lipid lowering therapy. So there's a significant gap in terms of identifying and managing people that we know are at high risk. And then when we do get high risk people, they're not getting the treatments which we know are evidence-based. Next slide, please. However, even when we do that, if you look at the picture on the right, you can see that the risk reduction that we get with, for example, statins is not 100% in relative terms, and it's indeed quite small in terms of absolute risk reduction. So if we take myocardial infarction, for example, with a 30% reduction, there's still 70% happening sometime down the track in people that are on effective doses of best practice medications and management. And that's what we're talking about today. What's left over? What are other things that might be not appearing in our standard risk equations that are contributing to this residual risk? What can we do about identifying them? What can we do about managing them? And we'll be focusing on inflammatory pathways, on prothrombotic pathways and metabolic pathways, all of which have been identified as being independently associated with risk of cardiovascular disease and probably contribute significantly to what we're calling residual risk. Next slide, please. So I'm going to start with an example. Nico, he's a 49-year-old male who lives in a regional location, and he's been invited to come in and have a heart check. He's got a bit of back pain and he takes some ibuprofen for that. He's got a family history of fairly early cardiovascular disease, and he's also got a Maori background on both sides of his family. You can see his social history there. He's not smoked, drinks moderately, and I want to focus on his initial investigations where in each case his blood pressure, his cholesterol, his triglycerides are all up around being mildly elevated, HDL 1.2, and that gives him LDL calculated at 4.8 and a non-HDL cholesterol of 5.7. And his HbA1c is also in that intermediate range. So next slide, please. So, oh, sorry, we'll leave that one if you would, because we're going to move first into our first presentation. I'm sorry about that. Just think about Nick as we talk through these next presentations, because we'll come back to him at the end, see what happens to him and see what we might have done at that stage when he first presented. But it's a great pleasure to introduce Sophia Zungas, who's head of the School of Public Health and Preventive Medicine at Monash University and a world-renowned investigator in diabetes and clinical trials, public health. And she's going to talk about residual risk, particularly in diabetes, what we know particularly from the local Australian experience. Thank you very much, Sophia.
Thanks, Gary, and thanks for the kind invitation to participate tonight. I'm going to share my screen and hopefully the technology works. And, oops, sorry, hasn't gone to the sharing for a second. I think we've got there. Thank you, and thanks for that kind invitation. These are my disclosures, and I would also like to extend my acknowledgement of traditional custodians of the lands which we speak. For me, it's the Wurundjeri people of the Kulin Nations, and pay my respects. So I've taken the approach of reviewing residual cardiovascular risk in diabetes from a different perspective, Gary, and I'm not going to focus on new areas beyond those, the traditional, because I went back and had a look at the data that we have in Australia, certainly around how we're managing cardiovascular risk, and I was really shocked that seems to be a lot of work we need to do in managing, you know, the conventional cardiovascular risk factors. And so you will all know that cardiovascular disease is the leading cause of morbidity and mortality for people with diabetes. And indeed, the contribution of many risk factors, hypertension, dyslipidemia, obesity, hyperglycemia, physical inactivity, oxidative stress, and low-grade chronic inflammation, and a number of other areas that we may discuss this evening. We also know that, in particular in diabetes, there's large benefits observed when we manage multiple cardiovascular risk factors simultaneously. You all know of the Steno trial, small trial, managed a range of risk factors and showed a very large, almost 40% reduction in cardiovascular events. The advanced trial, similarly, multifactorial trial, blood pressure lowering and glycemic lowering. When you looked at the combined effects of the two, a very large benefits accrued. But what we do know is that even in the range of trials that we've observed, managing multiple risk factors can be difficult to achieve and sustain. And I want to show you our Australian experience about how we can look at that and what we're doing in terms of benchmarking and audit feedback to address that. There's also another approach that's recently emerged that you'll all be familiar with, where, you know, new agents have come on board, have been introduced as glycemic lowering agents, and indeed, after their cardiovascular safety trials have reported, and the findings have shown that these specific classes of drug, in particular the SGLT2 inhibitors and the GLP-1, and now the more recent dual agonists are showing that there are independent effects on cardiovascular lowering beyond the traditional cardiovascular risk factors, and we might think about what's producing those benefits. So I wanted to bring you back to that approach of cardiac risk and how we might look at the conventional risk factors. And I was very interested to find this paper, which was published in 2018. And this is looking at data from the Swedish National Diabetes Register from 1998 through to 2012, where they looked at patients with type 2 diabetes. And indeed, they had more than 270,000 accrued over that period. And they compared them to matched controls from the general population who did not have a history of cardiovascular disease. They examined 5 risk factors: an HbA1c greater than or equal to 7, LDL-C greater than or equal to 2.5 millimoles per litre, albuminuria, smoking, and elevated blood pressure. And you can see the parameters they looked at there. They had a median follow-up of 5.7 years. And they wanted to look at the excess risk of MI, stroke, heart failure, and all-cause death in comparison to the general population. And aside from, we'll take heart failure aside, what they found invariably, and you'll see in those forest plots there where they look at the different age groups, they look at the different risk factors, invariably the risk of the population with diabetes, when all those risk factors were managed to target, their risk was equivalent to the risk of the general population, and really challenged this paradigm that diabetes, beyond traditional risk factors, there were a massive excess risk that wasn't able to be managed. And I think Gary's alluded to that, when he talks about 90% is attributable to the common risk factors, and likely to be an additional 10% or so related to other things that we're either not measuring or not addressing adequately. So one study suggesting that we could do more just based on focusing on those traditional risk factors. It was a little different from heart failure. Those general metabolic parameters didn't account for all that risk, and we might discuss later what that's attributable to. So we wanted to, taking that premise, I wanted to look at the snapshot of the data from our Australian experience, and we run a national benchmarking activity. It delivers reports to Participating Diabetes Centre and also an annual pool report of the state of the nation. And in 2021, despite the COVID pandemic, we had over 4,000 patients registered in that activity from 68 diabetes centres. 45% were female, 70% had type 2 diabetes, and those that had type 2 diabetes, median age of 65 and a duration of 13 years. Of those participants in that register, the overall complications you can see there, a bit less than 60% reported no complications, and about just over 40% either one or more complications. And you can see there in more detail that, in fact, myocardial infarction, coronary intervention, stroke, heart failure, end-stage kidney disease were all reasonably common in the cohort. So it was a mixture of both a primary and secondary prevention cohort. We might like to look at whether we're achieving targets through examining mean levels of lipid levels. And this is just reporting on the data that we had in terms of total cholesterol, HDL, triglycerides, and LDL. And you can see there, generally speaking, more treatment of lipids amongst the population with type 2 diabetes. And the mean levels actually weren't too bad. If you look at the median of total cholesterol, HDL, triglycerides, in fact, you might say, well, they're on average achieving target. But I don't think that's telling us the whole story. And you can see in the bottom panel there, when we separate the groups based on whether they're on lipid modifying therapy or not on lipid modifying therapy, that certainly the targets are being better achieved in those that are being treated actively. Another way we might look at that, rather than just looking at average levels, and we do this in benchmarking, is provide the percentages achieving targets. And this is really compelling information for the health professionals. And then they take this information to take it back to put in place processes that might improve. And you can see there a reasonable number on lipid modifying therapy, 60%, and also on antihypertensive therapy. We've still got more work to do in terms of smoking. And we've seen a recent resurgence of smoking amongst particularly young people, even young people with diabetes. But clearly on the bottom there, in terms of all the risk factors, considerable numbers not achieving what would be considered to be best practice target levels. So lots of room for doing extra work to improve all those conventional risk factors. And in particular at the bottom there, overweight and obesity, which is a particular issue when managing populations with diabetes. Another approach we can take is looking at prescribing and treatment gaps. And this is looking at, in particular, lipid modifying therapy. These are all the individuals registered with a history of cardiovascular disease. And you can see there of those that had reported a history of cardiovascular disease, a significant number who had a total cholesterol of over 4 were not on lipid modifying therapy, 15%, 16% there. But then looking at the treatment gap of those that were already on the lipid modifying therapy, what proportion were not achieving our target? And again, almost a third. So quite a lot of work for us to do there. Another approach we may look at in terms of residual risk is residual risk and removed risk. And this is based on reported effects from large randomized clinical trials. And this is from a paper recently published in Cardiovascular Diabetology, where they looked at the different approaches and the introduction of the new pharmacological approaches to cardiovascular prevention in diabetes, in particular, as I've said there, the GLP-1 receptor agonist and the SGLT2 inhibitors. The first panel there is intensive glucose control, and these are all based on effect sizes based on meta-analyses of groups, grouping the trial outcomes for those particular approaches. And you can see there the red panel is looking at the number that haven't, the residual risk, if you like, and the green panel, the treatment effect of that particular approach or class of drug. Clearly, with DPP-4 inhibitors, there's no particular additional benefit of having those beyond for glucose lowering, and in fact, moderate effects on glucose lowering when compared to other agents. But you can see there clear benefits for kidney outcomes and MACE of those two approaches of GLP-1 receptor agonists and SGLT2 inhibitors. Since then, there's been a lot of speculation of proposed mechanisms and targets, and it's important to think about that, because if the effects go beyond the effects that they might have on traditional cardiovascular risk factors, glucose, blood pressure, weight, we might think of new therapeutic targets being explored as a result of these agents. And you can see there lots of proposed approaches for benefit related to the SGLT2 inhibitors. I won't go through all of those. I'm sure you're familiar with them. And similarly, a different suite of potential proposed mechanisms for GLP-1 agonists. And so let's look at what's the state of play in Australia in terms of prescribing of those two classes of drug. And I have the updated data for 2021. Haven't been able to alter the figures yet, but this was from our publication in 2021, looking at use of the SGLT2 inhibitors and GLP-1 agonists in Australia. And you can see there with the evidence emerging clear increases. Gender differences certainly are biased to more prescribing of GLP-1 amongst women. And, that's it's of interest and likely related to the weight management approach that drug was developed to address, but a clear preference for SGLT2 inhibitors amongst men. And there may be other reasons for that related to the side effect profile or other tolerability issues. What's interesting to note, and I can update you on, in 2021, in fact, the use of SGLT2 inhibitors surprisingly has actually plateaued around the 30 to 40%, which is a real implementation issue for us. However, the GLP-1 use has increased, and this is despite issues with access to the drug. So clearly lots more work to do around increasing uptake of these drugs that have been proven to have cardiovascular benefit. There's a lot of speculation around why we're not seeing the uptake with these two new classes of drug that we might expect. This is from a publication exploring clinical inertia. Just to remind us that there's a number of biases in the way we prescribe, our personal clinical experience. Do we want to really be sure about a drug and have experience using it? Do we not have sufficient time to reevaluate treatment, the opportunities for that? Is it around interdisciplinarity? We've got a lot to do, a lot of competing demands. Is it around our knowledge, and do we need to improve education? And that's part of what we're doing. And then the competing priorities, when you've got a number of risk factors to manage, a number of conditions and complications to consider, the competing priorities can often be an issue. So I think it's onus on us to reflect on that and consider what in our prescribing behaviour, what we can do to improve that. The other thing is drug adherence and persistence. And this is my second last slide, but really to take a look at the real world experience, because clinical trials can be quite sterile in terms of the applicability. People often talk about the selected population not really reflecting what we do in routine clinical care. And the approach to monitoring those patients within trials may be leading to better adherence or persistence. But this is looking at real world data that suggests that discontinuation may be much worse than what we actually think. And in fact, as observed, it can be a reduction in use of around 60% at 1 to 2 years. And what we see there is the unrealised efficacy, and maybe related back to the unrealised residual risk that we aren't able to tackle because of adherence or discontinuation of therapy. So just again to reflect that we may need to consider that. So I've got my last slide with my take-home messages. My view and my contention is that to reduce a risk and residual risk in diabetes, we need to do better in managing traditional cardiovascular risk factors. We need to increase the use of agents proven to deliver cardiovascular benefits, as I've shown. And we need to proactively consider how we tackle clinical inertia and persistence and adherence with systems approaches. And in our audit feedback, we're trying to do that by providing people with data, with information around their prescribing and benchmarking it to their peers so they can think about what quality improvement strategies they can put forward. And finally, once we've done all that, my view is then we should pursue novel mechanisms and targets. And I'm hoping we can hear about some of those from our other speakers: inflammation, new understanding of lipid and lipid metabolism, and polygenic risk. So happy to stop there, and thank you for your attention.
Thank you very much, Sophia. So you've really made a case that we can do much better with what we've got, but you've given us a good lead into our next presentation, which is Peter Saltis from the University of Adelaide and Samari, and he's going to talk about some of the other novel biomarkers, and he'll probably tell us why there's a little bit of interest in Lp(a) at the moment too. So thank you very much, Peter.
Fantastic, thanks, Gary, and that was a terrific talk from Sophia to follow on. Can I just confirm that you can see my slides okay there?
We can.
That's all good, Gary, thank you. So welcome from Adelaide, good evening from Adelaide, and I'm going to focus on one quirky biomarker and residual risk factor that we continue to learn more and more about, and that's lipoprotein A, or Lp(a). We've known about Lp(a) for decades, but it's really coming into its own in recent years as more data come to light, but perhaps more importantly, the prospect of new therapies to lower it. And I'll touch on this towards the latter part of my talk. Here are my disclosures. So Gary introduced tonight's topic by talking about residual risk factors, and I could have spoken about inflammation or thrombosis, but I thought it was a topical time to talk about Lp(a) because you're going to be seeing a lot more testing for it, both in your own practices and through the cardiologists treating patients with cardiovascular disease. What is Lp(a)? Well, perhaps the best description I've heard of it is that it's a quirky type of cholesterol related but different to LDL. In fact, Lp(a) is synthesized by the liver through the assembly of LDL, so apolipoprotein B, and a glycoprotein called ApoA. Lp(a) is largely genetically determined, very little effect of diet or lifestyle. So a person's Lp(a) level is pretty much prescribed quite early in life, and it follows that knowing the Lp(a) with one measurement usually suffices throughout adulthood, at least until we have treatments available that lower it. Lp(a) levels vary widely in plasma, largely because of genetic determinants. And one of the challenges we have in Australia is that different laboratory centres use different methods to measure it. And so depending on who measures the Lp(a), you might get a result in mass units or more preferably in molar units using what we call an ApoA isoform independent assay. The conservative normal cutoff level for an Lp(a) is less than 50 milligram per deciliter or less than 100 nanomole per litre, and I'll come to this in a moment. We know that Lp(a) is an independent driver of atherosclerosis. What's interesting is that it is also potentially modifiable risk factor for calcific aortic stenosis. And it's been estimated in some studies that perhaps 1 in 14 myocardial infarcts might be caused by high Lp(a), and maybe as many as 1 in 7 cases of calcific aortic stenosis. Lp(a)'s effects on atherosclerosis are multifaceted. It has pro-inflammatory effects because of its affinity for oxidized phospholipids in cell membrane. It behaves like LDL in that it's taken up by immune cells like macrophages to form foam cells, which are atherogenic. It also interferes with endothelial and smooth muscle function in the vessel wall. And the apo-A moiety itself, through these Kringle domains, has some homology with plasminogen, and so it follows that it can interfere with the plasminogen fibrinogen pathway in the body, leading to prothrombotic consequences. How common is it to see a high Lp(a)? Well, as I indicated, this is genetically determined and indeed ethnically determined. In Caucasian Australians, about 1 in 5 will have an Lp(a) above the cutoff. In Africa, we see the highest rates. Southeast Asia, also higher. Chinese and Japanese, lower prevalence of high Lp(a). In coronary care units, where we're seeing obviously patients with coronary disease, the prevalence of a high Lp(a) might be as high as 35%. Now, Lp(a) has been shown through many years of research to be an independent determinant and risk factor of atherosclerotic cardiovascular events. That risk is dependent on the concentration of Lp(a), so it is concentration dependent. When you see an Lp(a) level of around 50 to 100 milligram per deciliter or 100 to 200 nanomole per litre, you're looking at about a relative increase in risk in the order of 25 to 50%, and that will be despite the use of drugs like statins. When you push to high and very high Lp(a) levels, those risks increase considerably. What's important is that a number of studies in recent years have shown that this is both an additive but also independent risk factor on top of some of the other risk factors we use, for example, family history or calcium scoring, which many of you will use in primary prevention. So, for example, this study of 6,500 subjects with calcium scores and follow-up for at least 3 years demonstrated that if you have a high Lp(a) level, in other words, in the top 20% of the population, in conjunction with a calcium score of greater than 100, your risk is increased by almost 5-fold compared to if you don't have either of those factors. And you can see there the increment in having a high Lp(a) in that top 20 percentile compared to an Lp(a) level that is within the normal range from 3 to 4.7-fold in this study. The European atherosclerosis guidelines have suggested that Lp(a) should be tested in virtually everybody. A few months ago, the Australian Atherosclerosis Society published our first position statement about Lp(a). We took a slightly more conservative approach as to who to test it in. In essence, we have recommended that testing for Lp(a) should be considered in adults who have established or very high risk of atherosclerotic disease, whether it be coronary, peripheral, or carotid, particularly where the test result will lead to a change in therapy, either because of problems with adherence or the need to intensify therapy. We've also honed in on those individuals with early or aggressive vascular disease, so people with vascular disease before the age of 60 for women or 55 for men, those with a family history of similarly early atherosclerotic disease, or where we know that there's a family history of hyperlipidemia and high Lp(a). We've also flagged individuals who have stubborn LDL cholesterol that does not respond predictably to statins or other therapies as a group, and those individuals with recurrent or accelerated atherosclerosis. What do we do about high Lp(a)? Well, as of now, there are no TGA-approved treatments to lower Lp(a) that have been shown to lower cardiovascular events. The general use of Lp(a) in 2023 is to use it as a guide as to what we should do with other risk factor modification. And in a nutshell, when the Lp(a) is high, that really gives us extra impetus to push the envelope of managing other conventional risk factors. For example, targeting an LDL cholesterol that is lower, pushing the threshold to below 1.4 compared to 1.8, perhaps being more aggressive with metabolic or antihypertensive treatments. There are treatments that are available that will lower Lp(a). Their effects have not necessarily been linked to Lp(a) lowering as yet, although that may be borne out in future studies. So, for example, the old oral drug niacin, which we don't use much of, can lower Lp(a) by 25 to 30%, but niacin has not been shown to have additive benefits for cardiovascular outcomes on top of statins. PCSK9 inhibitors, which many of you will become more and more familiar with the changing guidelines around LDL management, also lower Lp(a) by a similar level of about 30%. And we have on the horizon, one of the reasons we're presenting this topic to you tonight, are new RNA-based therapies that will lower Lp(a) by up to 100%. And I'm going to touch on those in just one moment. So very quickly, the effect of PCSK9 inhibitors. The data on this slide relate to evolocumab or Repatha from the Fourier data. In this particular study of almost 30,000 subjects with residual LDL cholesterol risk and established atherosclerosis, the use of evolocumab lowered Lp(a) by about 25%. And what was interesting in sub-analysis was that the reduction, both relative risk and absolute risk reduction with these agents, was greater in those individuals who had a high Lp(a) level to start with. And so in those graphs, you can see that if the individual had an Lp(a) of greater than 120 nanomole per litre, their relative reduction with evolocumab was 25% compared to 11% if they had an Lp(a) within the normal range. So this is a group of patients that may benefit, especially from intense LDL lowering with evolocumab. We're seeing RNA therapeutics introduced across the spectrum of lipid conditions. Broadly speaking, RNA-targeted therapies try to block the translation of messenger RNA into protein as a way of reducing that protein expression and then the subsequent lipid effects. And in clinical trials now, we have two agents used for Lp(a). One that uses a technology called antisense oligonucleotides. It's a single-stranded RNA that gets into the nucleus to work. These are injectable medicines given weekly to monthly. The other type of treatment that is emerging, both for LDL cholesterol but also Lp(a), is small interfering RNA technology, which works in a slightly different way and has a more durable effect of up to 6 months. And so in the Lp(a) realm, we have an agent called pelacarsen, which uses this antisense oligonucleotide technology. And we have at least 2 agents that have been used in early phase trials using this alternative siRNA technology. Pelacarsen was shown recently at different doses ranging from weekly doses to monthly doses to be able to lower Lp(a) by around 80%. And with excitement, we await for a phase 3 trial that is ongoing called Horizon, which will test the monthly formulation of pelacarsen, 80 milligrams every month compared to placebo in patients who have a high Lp(a) level and established atherosclerotic disease. So this will follow up subjects for 2.5 years to see whether the effect of lowering Lp(a) actually reduces myocardial infarcts, strokes, and cardiovascular death. And that'll be a really important landmark trial to tell us whether not only can we use this as a residual biomarker, whether lowering it actually makes any difference to outcomes. We suspect that it will, but the data needs to follow.
Thank you.
One final word.
Thank you, Peter. I might just interrupt, and we might come back to that at the end, because this is obviously very exciting, and it's great to see as this final slide you've put up, it shows
just the evolution of
a variety of options available to us. But thank you very much.
Thank you, Gary.
And I'll hand over now, because we've been talking mostly about things that are based on prediction from populations, and we want to know what happens at the individual level. And of course, we have technologies now that will allow us to do that. And it's a great pleasure to introduce you to Professor Sandosh Padmanabhan, who has led the way in a number of these studies in terms of genetic determinants of cardiovascular disease and how we might use that for risk prediction. So thank you, Sandosh.
Thank you. I'd like to thank Gary and the organizers for the opportunity to present at this webinar. So I'm going to speak about polygenic risk scores. And why are we here? Why are we discussing about polygenic risk scores in residual cardiovascular disease? Just to give you a short background, over the last 15 years, we've seen enormous advances in genomic studies of common diseases. So this includes studies of cardiovascular risk factors, cardiovascular diseases, among all other diseases. And we've discovered hundreds, indeed thousands of single nucleotide polymorphisms associated with cardiovascular risk factors. And these have come from studies which involve millions of participants. Single nucleotide polymorphisms are single letter changes in your 6 billion strand of DNA. And despite significant successes in identifying these single nucleotide polymorphisms, we've not really made much headway into getting them into clinical practice. So the clinical applications of all these discoveries are still not realized. But if you look at genome, if you look at your genome, the genome does not change throughout life. It's fixed for an individual at conception. So that means there is a potential for using genetic risk as a marker for stratification and early life risk prediction. So you could use genetic risk to provide risk mitigation measures across the whole spectrum at the late stage of secondary prevention, but on through to primordial prevention. As I mentioned, the individual SNPs that we've found associated with common diseases, including cardiovascular diseases, do not have a lot of impact on individual risk prediction. So we have these thousands of genetic markers. So what do we do next? Maybe we could add all of them together and produce a score that may provide a metric of overall genetic risk for an individual. So for instance, we could take all the SNPs associated with coronary disease and create a risk score for coronary artery disease. Or we could take millions of SNPs associated with all your cardiovascular risk factor and create a polygenic risk score for cardiovascular risk. This is easily calculated. It's still in the research domain, but there is a lot of interest in polygenic risk score. The problem is there are equal number of people who are for it and an equal number against it. So there is a level of equipoise in using polygenic risk score, and it boils down to evidence. For primary care physicians, general physicians, and also secondary care physicians, the problem we will face is most of the direct-to-consumer genomic companies like 23andMe now will offer polygenic risk score calculations. So in their 23andMe report, you will have polygenic risk scores for coronary disease, for obesity, for diabetes, for breast cancer, colorectal cancer, everything. Everything has got a polygenic risk score attached, easily calculated. And you may see a patient who will whip out their 23andMe report and ask for advice. So I'll give you a background to what all this means. I'll use the example of blood pressure because that's my area of research. Most of you may understand or may encounter genomics of hypertension primarily through encountering patients who've been diagnosed with, or children who've been diagnosed with rare syndromes like Liddle syndrome or Bartter syndrome. These are very rare genetic mutations that can increase or decrease blood pressure. And there are about 30 or so odd mutations. I've presented that in this figure. The chromosomes are arranged circumferentially, and the large red circles indicate the location of the mutations. These are rare mutations. They don't have any major impact on public health. What we're interested in essential hypertension. So that's polygenic multifactorial. And we have about 1,500 single nucleotide polymorphisms associated with blood pressure, and that's across the entire genome. The small size of these circles indicate the effect. So individual effect of each SNP is very, very small. If you take all the SNPs together and look at their impact on blood pressure, it's about a millimeter mercury or less than a millimeter mercury. But this is genetic risk. So genetic risk is lifetime risk. So this is even a 1 millimeter increase in blood pressure over the lifetime will contribute to cardiovascular risk. The slight problem with these single nucleotide polymorphisms, not only for blood pressure, for any other trait, coronary disease, diabetes, are that they are not exclusive for the trait studied. So each of these SNPs, the histogram on the circumference indicates the number of non-blood pressure traits that are equally significantly associated for each of these SNPs. And you can see that all these SNPs are not exclusive for blood pressure. They are associated with a lot of traits, including traits that are linked to blood pressure, like BMI, like physical activity, salt intake. So we have a complex picture here. We've got a lot of discoveries. We don't know what to do with them. So if you add up all these risk variants, you will get a normal distribution. And if you get a normal distribution of risk, you can divide people into various strata of risk, from high risk at the upper tail of the distribution and low risk. Do these predict outcomes? Well, if you look at blood pressure risk score, you find that those at the highest risk have a higher risk of hypertension compared to those at the lower risk. And this is lifetime risk, but you don't see that much of a differentiation in the younger age, which is where genomics is supposed to play a role. Same story for coronary artery disease. If you look at quintiles of polygenic risk, of course, those at the higher end of the distribution do have higher risk. But based on age, not a lot. Do polygenic risk provide incremental value over conventional risk factors? So if you look at the left-hand graph, these are conventional risk factors, and the y-axis is the area under the curve. When you combine all the conventional risk factors, you have an area under the curve of about 68. And if you add polygenic risk on top of that, there is a slight increment in discrimination of coronary artery disease risk. But what's the actual risk? How can you use polygenic risk clinically? If you look at the black line, these are individuals who do not have familial hypercholesterolemia mutations. You find that the polygenic risk score impact is almost a flat line across most of the range of polygenic risk, and only an uptick in risk at the upper end of the distribution. Of course, the line is slightly more steeper in patients who have familial hypercholesterolemia, indicating that the incremental value is probably small. PCSK9 inhibitors, we've seen that before in the previous discussion on Lp(a). Again, those who have high polygenic risk have a higher absolute risk reduction with PCSK9 inhibitors than otherwise. The final slide is the big problem with polygenic risk score is we do not have as yet evidence of clinical utility. We don't have randomized controlled trials. We don't have cost effectiveness trials. What we know from other studies is whenever polygenic risk score is implemented, the number of prescriptions increase automatically, but we do not know whether that's related to outcomes. More importantly, most of the polygenic risk scores are derived from populations of European ancestry. So there are issues with equity and diversity and disparities that need to be addressed before this can come into clinical use. Finally, the last slide, in summary, polygenic risk scores define a lifetime risk trajectory. It can capture risk not quantified by family history, and it can quantify risk not quantified by monogenic mutations. Importantly, polygenic risk is an estimate of a population. So if an individual brings you their polygenic risk score, currently you're extrapolating a population risk to an individual level, which is not ideal. I mentioned equity and diversity limitations. There is accruing evidence that even the increase in risk due to polygenic risk can actually be controlled or overcome by small changes in conventional risk factors like blood pressure reduction, weight control, all that can overcome the excess risk posed by polygenic risk score. So currently there is you will hear a lot about this over time because there is a lot of work going on. In the UK, the 5 million, our future health study is going to calculate polygenic risk score and look at its impact on coronary artery disease. But as of now, it's research use only, and we can use this to consider people at the higher end for lifestyle intervention. But beyond that, I don't think it's right for clinical use. Thank you.
Thank you very much, Professor Padmanabhan. That's a wonderfully balanced view of what is an area that clearly we need to watch the space, and things will develop. But right now, I think you've summed it up so nicely. I want to come back now to our patient, Nick, and perhaps I can have the slide up about what's happened to him subsequently. Now, when you put the numbers in for his that I showed you before, he comes out through our particular cardiovascular absolute risk score of a risk of 7% in 5 years of having a major event. So that puts him into the low risk group. But 2 years later, he had an event. Next slide, please, just to show you what's happened 2 years later. And he's been managed quite reasonably. So he's a perfect example of residual risk. He's now on a statin. He's at a high dose. He's on an ACE inhibitor. He's on a beta blocker. 2 years later, probably doesn't need that after an infarct, but he's on it, and he's on aspirin, and his blood pressure, LDL and HbA1c are all borderline. And our question now is for you to do some work, and that is a poll will come up, and you can answer this with more than one response. What would you do now for this man? Order a calcium score, start ezetimibe, amlodipine, measure his Lp(a), put him on an SGLT2 inhibitor, start colchicine, misspelt, but I think you know what it means. Your answers will come up in a moment if you would hit the button. Okay, you're going to do all of those. There's no right or wrong. I think there's one wrong in this, and that's the calcium score. We already know he's had an event. You're already going to, what are you going to do if his calcium score is high, which it almost certainly would. All of the others are reasonable options, I think, that could be considered. And again, I think probably you could make the same argument about Lp(a), but I'd be interested in the panel whether they've got any reflections on this. Peter, he doesn't come into your little Lp(a) category, does he?
Yeah, look, he would, Gary. I mean, based on the early nature of his family history, the father with an infarct at 55, and the fact that he's had atherosclerotic disease himself at a young age, what Lp(a) would do would highlight that perhaps we'd target an LDL, even lower than the current Australian guideline of 1.8, as an example. But of the options presented, I would certainly put him on ezetimibe, which will lower his LDL by another 15 to 20%, at least get him into the ones. His blood pressure should be lowered, so I think amlodipine is a good choice there. I don't think he yet qualifies for the use of SGLT2 inhibitors.
Sophia might comment on that, although she's nodding her head.
I'm nodding my head because I agree. I don't think he would qualify. We don't know what his ejection fraction is, but certainly he doesn't have diabetes, and he wouldn't qualify based on need for a glycemic effect beyond, heart failure protection.
So you're not worried about his HbA1c of 5.9%?
No, it actually doesn't meet the criteria for diabetes. He's got pre-diabetes. His HbA1c would need to be above 6.5 to make a new diagnosis of diabetes. Having said that, he's started on high-dose statin. He's going to get ezetimibe, and we need to monitor that closely because, as you might know, statins can increase risk of future development of diabetes.
I think one of the other things to note is that his ethnicity, with his Maori background, we know from data from New Zealand that is associated with a higher risk, as indeed is the Indigenous population in Australia too, and that's something to take into account. The raw numbers are not telling you the whole story here, as we all know. Look, I'm going to introduce Jan Radford to you now, because she's going to sort of put our feet on the ground and talk about the sort of general challenges of achieving these targets in general practice and how she manages that. And please don't feel restricted to our discussion about Nick, Jan. Any reflections you've got on what we've been talking about tonight?
Thank you, Gary. I think it's quite sad to think that this young man went on to have his heart attack and has now definitely got his cardiovascular disease. Presumably it was there all along, his high risk. The thing about Nick is engaging with him in a long-term therapeutic relationship with yourself, with the practice. And he's a young man, relatively speaking, who's a truck driver. He's sedentary potentially. He probably drinks a little too much alcohol. We don't know how large he is. Is he obese? We don't know what his diet's like, but we know he eats a bit too much fast food when he's on the road. So there's a lot about Nick's lifestyle that concerns me. I would, the issue is to try and engage with him so that he comes back and keeps engaging in treatment. And I was very much applaud the, so I think it was Sophia who said that, audit and feedback is a really good way of making sure that you know where you're going. And one of the things that can happen with these patients is that they just slip off the radar. They don't come back for their statin script. You don't necessarily keep track of them. So keeping a track of your patients and being able to engage if they have not come back, the chance that he'll stop taking his medication is there. So this is a problem. I think so. It's making your practice so that you can appeal to these people. It's affordability in Australia at the moment. Affording your medicines, affording to come and see the doctor, having to work long hours because you've got to have cost of living stress. So all of these issues, you have to sort of know the person. And that, I think, is the big challenge, let alone when we have things like COVID come along and sort of sometimes imperil this routine but vital work that we have to do. So I think there's a lot of relationship building, and one of the things we need to do is not just rely on the GP or the cardiologist or my exercise physiologist. I'd love him to see, but it must be a community effort. Our community must know these risks and must get on with it. Diabetes, obesogenic environments, etc., don't help. So I'd like to write I'd like to have it writ large, Gary, the interventions we need to do to help this man.
Thank you. Well, a lot of common sense in that. Look, we might move, unless the panel have got any other comments on that, we might move into some of the questions we've had from the audience. There are over 1,300 of you, so I'm sorry we can't answer every question that's been put up, but I'll just go through some of them. Number one is, can you please comment on the place of coronary calcium scores and whether a 0 score suggests no need for statin? I might just start with that one. Nick would have been somebody appropriate for a coronary calcium score when he first presented, because he was, although he was in the low risk category, he was near the borderline. He had a couple of factors that would suggest that maybe he was a little higher than the raw numbers from his risk score would suggest, and it might have been helpful then. If he was, the other part of the question about a 0 score, whether that suggests no need for a statin, the answer is not necessarily. If you do a calcium score in a young person, there are a significant proportion of them that have what we call soft plaque. That is, there's no calcium, but there is potentially a vulnerable plaque there. And I think I'd be playing it safe if somebody had risk factors and treating with statin. But Peter, you might have some thoughts on that.
I agree, Gary. I would argue that in Nick's case, when he first presented, our guidelines would suggest that he should have already had his LDL targeted to 1 to 1.8 based on his father's history. So our guidelines would say that the value out of a calcium score at his age at the level of primary prevention is limited because he's under 50. In individuals who describe chest discomfort, you can get a Medicare rebated through a specialist CT coronary angiogram, and that will pick up the soft plaque that Gary speaks of. Where individuals are reluctant to take statins despite guidelines, for example, based on family history, the calcium score can value add to risk stratify, to change the risk classification maybe to convince individuals who are ambivalent, or sometimes to reassure us that maybe the choice of statin can be deferred.
Thank you. I've got another one here, and you've sort of touched on all of this, Sandosh, but maybe you can address it. Is CHD inevitable in people with a strong, very strong family history, with, for example, FH or similar, who don't seem to have any other risk factors?
So yeah, that's a very good question. And I think what happens with family history has so far been considered as the most inexpensive genetic test for cardiovascular disease risk. Lots of studies have shown that if an individual has a family history of premature cardiovascular disease, they are indeed at a higher risk. We did a study a few years ago in the Glasgow Blood Pressure Clinic where we looked at people who had a family who were referred to the secondary care blood pressure clinic for cardiovascular risk prevention because the GPs noticed that they had a very strong history of premature cardiovascular disease. These patients were referred to the secondary care clinic or even tertiary care clinic 10 years earlier than normal patients, normal hypertensive patients. When we looked at their outcomes, we reduced their blood pressure, we reduced their cholesterol, but their outcomes still remained high. They had higher risk compared to the hypertensive population who didn't have family risk. So there is excess residual risk in these patients who have a strong family history. This means that by the time a patient presents to the GP saying that they have a family history of cardiovascular disease, it's too late. I think the atherosclerotic damage is already set in. So the intervention should actually start even more earlier and possibly more aggressively than patients who do not have premature cardiovascular disease family history.
Thank you. I have another question about CRP as a risk factor. Whether Peter or Sophia want to talk about that briefly?
Yes, so high sensitivity CRP, Gary, can be used to indicate residual inflammatory burden. Atherosclerosis has an inflammatory substrate, and it's been shown over 20 years that if someone has an hs-CRP of greater than 2, when they're otherwise clinically stable, that is a portender of poor outcomes. In fact, some lipid-lowering studies suggest that an hs-CRP of greater than 2 is almost as risky as having an LDL of greater than 1.8. What we do about the high hs-CRP is probably another story, and that's probably getting to the use of anti-inflammatory drugs. And there have been different drugs tested. The one that's shown the most promise is colchicine, recommended in Canada and Europe, not routinely recommended in Australia, but you'll certainly see Australian cardiologists prescribe colchicine for secondary risk prevention. In my hospital in Adelaide, we use it in about 8 to 10% of patients following acute coronary syndrome.
Great, thank you. I don't know if anyone wants to add anything to that. I think we'll have one quick, it's a hard one to answer quickly, Sandosh, but a lot of people are sending off their DNA to get to services, consumer-based services, and getting their results and drawing big implications from that. Would you have any comment? I would presume that's happening a lot in the UK, certainly is here.
Yeah, we get these. I think the important thing to remember is that the risk predictions, so consumer genetic companies, the only thing they're good at is ancestry genomics. The risk predictions come from population studies, from genome-wide association studies in millions of people. So they are population estimates. Converting that to an individual risk estimate is erroneous. So if somebody comes to you with a 23andMe or a consumer genetic report with either polygenic risk score or individual risk score saying that they have got high risk, you have to look at whether it's a monogenic risk. Some of these do predict monogenic risks for certain conditions, then that's useful. If it's a common disease risk of obesity or diabetes or hypertension, I think that's not very accurate. So I wouldn't lend much credence to those values. Monogenic, yes, but otherwise, for now, no.
Okay, thank you. Look, there's lots more questions, lots more we could discuss. I think we could go on for another hour, but we're running out of time. Could I have the slides back on, please, Beck? But before that, if I could really thank all of the audience for, I think, your participation. We've had some great input from you, and of course our wonderful panel tonight. And I'm really grateful for the wise words we've heard from all of them. There is, as I said, it is Heart Week, so there's lots of things available to you. There's a heart health toolkit, which you can get off that particular website. Heart Week, you'll hear activities all of this week. Next slide, please. And this is the campaign page, which has got all of the activity if you want to get involved, including the toolkit, the resources pack, a whole lot of new health professional and consumer resources that have been produced, hot off the press, and once again available on that website. Next slide, please. And coming soon, probably in June, a new guideline for managing and assessing CVD risk that'll provide the latest evidence-based recommendations around many of the things we've been talking today. It will introduce a new risk equation, which is much better tailored than anything we've ever had before for use in the Australian population. And you can certainly register your interest via the Heart Week campaign page. And I think that's our last slide. Oh yes, important, the Primary Care Roadshow, where we're taking to PHNs in priority regions. We're bringing CVD clinical education to you, one workshop at a time. You can register your interest there. But thank you all very much. Have a wonderful day, and we look forward to future webinars and involving you.